So yeah, my name's David and Karen as well. We're both radiology registrars ST4s in the Severn Deanery. I'm going to take you through some MSK anatomy tonight. We're going to go over to ideally nail down some high yield topics. And we want to really try to go through some of the more challenging questions and how you might approach those, as well as going through a lot of this anatomy. We've said this a few times in the first few slides. We want to get the basics right, we'll sort of cover what we mean by that. Karen's going to take you through the upper limb, so shoulder, elbow, wrist, and then she's also going to do spine. And I think it's going to be a little break, and then I'll take you through hip, pelvis, knee, and ankle. So obviously MSK is huge. I'm sure you get this every time that people will come and do these sessions. It's not something which you're going to be able to completely cover in one evening in an hour and a half. We're going to focus on cross-sectional. Obviously, in the exam, there will be a lot of radiographs and there will be a number of MSK radiographs. Those are often not the most challenging. We've put a few in, but that's not what we want to focus on tonight, because hopefully, as you're going through your revision, you'll be picking up that knowledge, and that shouldn't be as challenging. We want to go through the slightly tougher questions to try to get you those extra marks. And if there is any pathology on any of the questions we've shown you tonight, then obviously please ignore that. The exam won't have any of that pathology. And again, don't be put off if you find some of these questions tough. They are tough, and hopefully that means you're going to learn a few things. We didn't think that it was as beneficial if we show you lots of images of hands and ask you to label metacarpal. So yeah, we're aiming for those hard ones. In terms of getting the basics right, with MSK, getting your left and right correct is really important. Basically, the exam wants to make sure that you have good anatomy for reporting, and it's important if you've got a paired structure on the screen in front of you that you are able to denote which hip is fractured, which neck of femur is fractured, for example. So if there is only one thing on the screen, so for example, if they show you a hand and they're pointing to the right scaphoid, weighted scaphoid, you don't have to say right at that stage. And some of the images won't have right or left put on them. So if it's a single structure, i.e. just one hand on the screen, and they haven't written left or right anywhere, then don't stress about that, because in those situations, you don't need to denote left or right. Obviously, if it's there, there's no harm in writing left if it says that on the screen, but you don't have to. And so don't stress if it doesn't show it on the screen. If there are two things on the screen and you omit it, I'm sure you already know this, you drop half of the mark. So well worth just getting into the habit. Every time we open up a question, think, can I write left or right? Every time, next question, can I write left or right? Can I write left or right? And then that means that you're not going to lose those questions through silly mistakes. And just very quickly, my feeling is that some of these questions are going to be tough for two reasons. They might show you a difficult piece of anatomy in a relatively normal plane, or they might show you an easier piece of anatomy in a harder plane. With these tough ones, sometimes you'll open up an image and you'll think, oh my goodness, I just don't really quite know what they're trying to show me here. Just take a moment, take a step back, work out what kind of scan it is, especially relevant for MSK. Is this a CT? Is this an MRI? If this is an MRI, what is that? Is that a bone or is that muscle, even, just to start out? Because your first instinct might be to panic. You can take a moment and work out where you are, trying to work out what's anterior, posterior, medial, lateral. And if you can identify some of those structures, then suddenly you might be able to unlock the difficult question and then rule out anything which it can't be. Some of these are very tough, and if you find that actually they're too tough, then you can always either come back to them or leave it till the end if you're finding that you're spending too long on one of those tough questions. Okay, so I'm going to hand you over to Karen now, who's going to crack on with the upper limb.
Hiya, my name's Karen, and I'm also one of the radiology registrars in the Severn Deanery. So starting off with the shoulder. Having said all of that, I am going to kick off with a plain radiograph, so bear with me. First things first, with any anatomy question, just take your time, take a breath and orientate. What modality am I looking at? Okay, this is an X-ray. So what, or a radiograph, what type of structure is the arrow pointing at? This is pointing at a bone. Okay, now we need to figure out which bone this is. We can orientate seeing the chest. Hopefully you can see my arrow. You can see the chest wall here with the ribs. Okay, so we're upper limb. And obviously the glenohumeral joint here. And then we look at more detailed anatomy. This structure here is a really good one to point out in the shoulder radiograph. Got the acromion, and we know that that should be articulating at the acromioclavicular joint with the clavicle. So we can say, okay, I've got clavicle here. Our arrow is pointing out a different structure, looks similar to the clavicle in some ways in this orientation, but it's not at the joint. So we know that anterior here is going to be the coracoid process. So I can just see that you can't see my arrow on my other screen. So I'm going to try using this. Hopefully you can see this, that this is the coracoid process. And here we've orientated knowing this is the acromioclavicular joint. And by isolating coracoid process, we know that this is anterior. And it's a good structure to know because it helps you to orientate. And again, this is just coracoid process on FAS. And then this structure here, I've already kind of alluded to, so I'll just move quickly on from this. We know this is anterior because we've got the coracoid process, and we know that this bone here is the lateral clavicle and it's articulating with the bone. So it's got to be clavicle and not coracoid process, because the acromion is here and it's articulating. So we've got the lateral clavicle there. And do be specific and right here. I think it's important to say that this is the lateral clavicle. If you were just saying clavicle, you might drop 1 mark if they're feeling particularly mean. Okay, on that note of being specific and right, we could say clavicle again for this question, but here there's something that comes up in practice questions that not everyone might have come across yet. So I think it's important to flag now, this is the conoid tubercle of the lateral clavicle. I'm just going to get you guys to post in the chat now. Hopefully it's working. So this arrow here, does anyone know what that is pointing to? Throw your thoughts into the chat. There might be a little delay, so we'll see how it goes. But hopefully we'll get some responses. And then we'll look at what the other arrow here is. If there is too much of a delay, then just have a think about it in your own time. Write down what you think, and I'll keep moving on for time because there's a lot of anatomy in MSK. So this one, as we haven't got any responses yet coming through, this is the greater tuberosity of, oh yes, I'm just getting some answers, greater tuberosity of the humerus, and there's some people have said greater and lesser. Here we're going to differentiate because we want to get the top marks. So we'll differentiate between the two. More laterally, we can see the greater tuberosity. And then here we've got the lesser tuberosity. So the way that you can tell is that the lesser tuberosity is a bit more pointed, and it's always more medial. Because here we've got the coracoid process again, and we know that that is an anteromedial structure. And if you think about I don't know if any of you have done ultrasound shoulder, perhaps, maybe not yet, but you always scan the front of the humerus and you've got the biceps tendon in the bicipital groove, which is made up by the greater and lesser tuberosities. That is an anterior feature of the humerus. So we've got the lesser, which is more anterior and medial, and then we've got the greater, which is a bit more smooth, a bit more rounded, and that's always going to be more lateral. Hopefully that's one where you can pick up the extra mark, being able to distinguish between them. Moving on to the next one. This is a kind of work it out question. So you have to have done the first stage where you've figured out that this is the lesser tuberosity. And then you have to know your rotator cuff insertions. What tendon inserts here? Feel free to post in the chat if any of these questions you think you know the answer to, or just have a think in your own time about what inserts there. Give it a second, see if anything comes through. Got lots of correct answers and thumbs up, which is good. Right, I'll move on for time, but the tendon that inserts here is the subscapularis tendon. And we know that because if you look at MRI, and lots of you might not have seen many MRIs, so I've got these here So these MRIs here so that we can scroll through and you can hopefully believe me on the anatomy. This is the top of the shoulder and we're looking at the axial plane. As you scroll down, you see this black structure here, and this is the subscapularis tendon. And we know that on MRI, tendons are black and muscles, here this is a subscap muscle and that's grey, and that's inserting on the lesser tuberosity. So you can see here is the lesser tuberosity and it's nice and pointy, it's more medial, just like we saw in that X-ray. And we've got more detail here because it's an MRI and you can see the soft tissue structure attaching subscapularis. And we'll go through some more MRI. Oh yes, we've got one subscapularis tendon answer in the chat, so that's great. Okay, going on to more MR. So I think most of you will probably have done more radiographs than MRI. Don't freak out if you see an MRI scan. Again, same principles, orientate yourself. So what type of structure are they pointing at? This grey here is muscle. Around here, if it were pointing here, we're talking more fat. And if we're pointing here, this is bone on MR, and you can tell that it's got a nice cortex around it, which is nice and black. And also just the shape of it, you can tell that this is the humeral head because it's articulating with the glenoid here. So we want to find muscle, and we can see the characteristic shape of the glenoid and the humerus articulating with it. What muscle around the shoulder is this going to be? It's quite superficial. It's a nice big chunky muscle. It's the deltoid muscle. Yes, perfect. We've got a few deltoids in the chat. That's great. Okay, same image, but now applying first principles. We've orientated ourselves to a good extent already, but it's just to note that this is the anterior portion of the shoulder. And so what tendon is this? Hopefully it will be a bit familiar to you, this appearance of the lesser tuberosity and the greater tuberosity. And we'll know that this tendon is again subscapularis tendon. Slightly trickier perhaps. I know you know that we're on the shoulder part of the presentation, but that's cheating. So let's apply first principles. How can we orientate ourselves if we're presented with an MRI slice like this? Because it can be hard. Okay, this is fat. I mean, it's a fat suppressed image. That's why it looks dark, because you can sometimes have fat where it looks bright, where you haven't suppressed the fat. We've got black outlining this structure here. So this is bone, and we're in a part of the body where there's a single bone, okay? But then just here we catch a bit of the scapula, and that's classic appearance for the scapula in that orientation. And then we've got black here in this part of the image, so that looks like lung. So we know that scapula is posterior structure, the lung is going to be medial, and we've got humerus, so it's all fitting. Going back to our question, this grey here, what type of structure are we looking for? It's a muscle. Anyone know what muscle this is? So this one is pectoralis major, because you can see that it's going off anterior to the chest wall, and it's not any of the muscles around the shoulder, for example. Deltoid here, it's got that classic streaky appearance laterally. So this is pectoralis major, so it's going off towards the anterior chest wall. And in that case, as we've orientated ourselves already on this image, this muscle here, pectoralis minor. Slightly different structure, but again, we're not going to panic. We've orientated ourselves to the shoulder with the humeral head. We've got the glenoid here. What structure might be triangular and black on the glenoid? Any suggestions? We can also orientate ourselves because you can see this bone. And again, this coracoid is really helpful for knowing that this is going to be anterior. And I think that's important when we're trying to be specific about this structure. So I'm going to keep going. This is anterior glenoid labrum. So the glenoid labrum is black. It makes a nice sharp triangular shape, and it goes all the way around the glenoid, lining it. And this is the anterior portion because the coracoid process is here. And that means that this is the anterior glenoid labrum. And I would put anterior because you just want to make sure that if you're sure it's anterior, you want to make sure you're picking up that extra mark. Back to radiographs. So a slightly different question now. What tendon passes through this groove? So then you think, okay, they're asking me about a groove and the tendon that passes through it. So the groove on the humerus is going to be the bicipital groove because it's pointing to the lateral aspect of the humeral head. What travels through the bicipital groove? It's in the name. It's the long head of the biceps tendon. And again, just small tip to pick up here, make sure that you put the long head of biceps tendon, because specifically it is that one that goes through the groove. And this is just MRI, so you get your eye in for seeing it in different modalities. It's the black tendon that goes through on the axial plane, this image is. Does anyone know which muscle this one is? Yeah, I can see supraspinatus in the chat. Brilliant. So orientate yourself first. We've got the classic Y shape of the scapula here. You can see the Y shape there. And this, the supraspinatus muscle, classically, well, it sits in the Y, in the top of that Y shape. So we know that this is supraspinatus, and the arrow is specifically pointing at the grey. It's not pointing at this black. And if you haven't seen that before, that's the tendon coming in of the supraspinatus muscle. So this, I would say, specifically would be supraspinatus tendon, but as I'm pointing at the grey here, this is supraspinatus muscle. Now let's see if you know, if you've got the supraspinatus muscle here, supra above, spinatus, spine, this is going to be the spine of the scapula. Here, I wouldn't worry about siding it because there's no label on there, and I don't think there's any way you can tell what side this is on. So don't spend too long thinking, gosh, how am I supposed to label this? I'm losing a mark here. You would get 4 points if I were marking it, and I'm not a marker, but if I were to mark it, I would give you 4 points if you didn't side it, as long as you got the structure right. Of course. Okay, how about this muscle? Any thoughts in the chat? Give you a second to orientate again. As you're thinking, I'll go through the structures that I use. So we've got the Y. This is going to be the scapula. Supraspinatus sits above the spine of the scapula. And yet we've got lots of infraspinatus getting posted in the chat. So this is the infraspinatus muscle. Perfect. Just below infraspinatus, there's another rotator cuff muscle. Feel free to post in the chat, but I'm going to keep moving for time. This is teres minor. And the last one that I think you need to know when you've got the sagittal plane of the shoulder is here. And we've already talked about this muscle a little bit, or the tendon. This is subscapularis. Okay. This one is slightly more tricky because it doesn't sit in just around the scapula as the rotator cuff muscles do. It kind of overlies those rotator cuff muscles. But we can still say that this is a posterior muscle, quite a good chunky muscle that's around the back there. And this is the deltoid muscle. Another one that's slightly trickier, but if you think about it, what lies above the level of the supraspinatus, and kind of if we were to scroll towards, sort of scroll through in the sagittal plane, we'd see it overlying supraspinatus there. This one is the trapezius muscle. And once, it's a lot easier when you can scroll through and see where these muscles insert. But if you can recognize them on one slice, that's great, because that's the aim for the exam. But it's slightly less realistic than being able to scroll through like this. So this, as you can see, is a sagittal image of the shoulder. And it's just to show you guys that here is supraspinatus, infraspinatus, teres minor, and subscapularis. If we scroll, I'm moving medial to lateral now. So if we keep scrolling, we can see that you get to the glenoid. Here you can make out some labrum and the glenoid, and then we move on to the humeral head. And these muscles are now becoming, their tendons are becoming more obvious. Is tendons coming in. And there they are, just inserting on the humeral head. And it's slightly tricky to see here, but they will be inserting on that humeral head there. So if you didn't believe me before, that's the sagittal plane. You can see those rotator cuff muscles and how they relate to the humerus. Okay. Moving on now to elbow. This is just a diagram to show above the elbow, just in case you did get a cross-section of the upper arm. The way that you tackle these questions, because they can be tricky, is orientate yourself again. So we can see in the corner of the screen, you've got some part of the body. I mean, this you can recognize as being a part of the body next to another part of the body with one bone in. So this is going to be the arm. So it's not going to be the leg, because you don't have that next to your thorax. So that's how you can orientate here. And once you know that you've got thorax here and you've got upper arm here, you can then start thinking about the muscles. Here we've got biceps brachii muscle. It's the more superficial muscle. If you come more deep, you've got brachialis. And then it's in the name, brachioradialis is more to the radial side or the lateral side. And then at the back, you've got your triceps muscle. I don't think you would necessarily be asked to split this down in sort of medial head, lateral head. If you're feeling brave and want to go for that, then please do. But I think it's reasonable to try, when you're trying to rationalize how much you're learning here, because there's a lot of anatomy to learn, let alone the physics, then triceps muscle is at the back. Biceps is the big one, superficial at the front. Brachialis wraps around the humerus here. And then brachioradialis is on the radial side. And I'll leave it at that for those. A few other quick tips for things to make sure you're getting correct and not losing the easy marks to pick up. The difference between the radial head and the radial neck. Make sure if the arrow points to the head, label it the head and try to be specific. They might give you a point for proximal radius or something a bit more vague, but I think if they're specifically pointing at the head, it's worth trying to go for those 2 marks and nail that question. If they're specifically pointing at the radial neck, then do say neck. The other thing about the elbow that I thought would be good to remember is capitellum versus trochlea. Make sure you're getting them the right way around, because it can be a little bit tricky to remember. I remember it myself because in Krytol, which is the way that you remember the name for the ossification centers of the elbow, which we'll talk about a bit later in the pediatric elbow, the C is next to the R, so capitellum articulates with the radial head, and obviously trochlea with the ulnar then. A slightly different question. If you pop in the chat what you think to this one. Again, orientate yourself. We can tell the classic appearance of the elbow. This is a radiograph. The question isn't, what is this bone? So don't be tricked and write proximal radius here. Make sure you're reading it. And the tendon that inserts there, yeah, we've got some answers. The biceps brachii tendon. Perfect. So that's a distal insertion. And yes, there is a label left, so it's good to put left. I personally just got into the habit of putting left and right on everything I could so that I knew I wouldn't miss it out on the day. So it depends how you like to do that. It's biceps brachii, and it's inserting on the radial tuberosity. Okay, so another tip is when they're pointing at a specific part of the bone, make sure you are labeling it as that specific part of the bone. This is an MRI, so we can orientate ourselves knowing that this is muscle, black linear structures, tendon, and then we've got bone because we've got nice black cortex around the bone. And you can note that this is the elbow because you've got the classic appearance of the ulna here wrapping around with the humerus articulating here. So for this question, I would be putting coronoid process of the ulna. I wouldn't just put proximal ulna or, yeah, we got lots of coronoid process of the ulna in the chat. So that's great. You guys are already specific and right. So great. It's slightly trickier when we talk about the muscles of the elbow. I don't think they'll go into too much detail on this, but there are some big chunky muscles that might be worth knowing if you're going to pick up those extra marks. So if anyone knows this one, it's certainly one of the trickier ones. So I wouldn't expect you to, but if anyone does know this one, then pop it in the chat. Okay, I'm going to keep going. This is the brachialis muscle. And you know it's that because it's relatively deep at this point, at the elbow. And you can see the biceps is up here. So don't mix the two up. If you've got a more superficial muscle, you can see the tendon coming off, which is, you'll just have to trust me, because I've seen the whole MRI for this patient. It is running down and it will articulate, will insert on the radius, on the proximal radius, as we've already talked about. So a tendon, a muscle that's clearly heading down towards the ulna, it's not going to be the biceps brachia tendon. It's the muscle is brachialis. Again, what tendon inserts here? For time, I'm going to keep moving on, but have a think in your own time. If you know this one, that's great. I would say for this one, the triceps brachii tendon. And yes, we've got some responses in the chat, and they are correct. So triceps inserts on the proximal ulna there. And that's the tendon going up here, the black structure. Okay, and this is to prove to you that I'm not making stuff up. You can see the triceps tendon here as we scroll through. You can see it inserting on the ulna, and there's the brachialis muscle coming down here. Biceps is up here, and it's sending off its tendon. It dives deep down and inserts on the radius. Slightly trickier muscle now. If you know it, chuck a response in the chat. But if you don't, please don't be worried, because this is getting into niche anatomy, but it's all possible. So firstly, take a step back. Can we orientate ourselves? This is a classic appearance of the distal humerus and the trochlea. Oh, we've got some correct answers coming into the chat, so that's great. And this is the ulna. We can know that this is lateral, this is medial because the ulna is here, and we've got the ulnar nerve here. And yes, this is the anconeus muscle. It just sits on the radial side of the ulna at that location. And I just wanted to point out here that if you did get a tricky question and you were asked to label this muscle here or this tendon here, just remember the previous image that I showed you, the sagittal of the elbow, where the biceps is quite superficial and it throws off its tendon quite soon relative to brachialis. So actually this tendon here is a biceps brachii tendon when you get to the level of the elbow joint, because we're quite low down now. So that's biceps brachii. Don't be confused and think that that's biceps. Okay. Another trickier question. If you know what it is, throw it in the chat. But I'll just chat through how I would orientate myself if I didn't know this was an elbow talk and I just had to say what this was. I'll start by saying, okay, it's a limb. It's got two bones. So we're talking either the lower limb, or so the lower leg, or the distal part of the arm, the forearm. The fact that these bones are relatively similar in size tells me that this is probably going to be the forearm, because the tibia is that much bigger than the fibula. So I've always found that as a helpful tip. And then when you're looking at what muscles these are, there's a classic appearance of the muscle that travels around here. And yeah, we got some answers in already. So that's correct. This is the supinator muscle, and it wraps around here, around the radius here, so that it can pull your forearm essentially in from pronation into supination. And you can imagine if it shortens, it's going to flip the arm like that. Okay. Next, just looking at different kinds of structures in MRI, just so that you've seen one or two of the slightly left field structures. Okay, so we've done fat can be bright when you haven't fat suppressed it, and that's like in this image. Bone here, we've got the dark around it, that's the cortex of the bone. We've got muscle, which we know is grey now, but we've also got a tiny structure here, which is labelled. I hope you can see on your screens that there are loads of tiny dots in there, and they are the fascicles of this structure. So if anyone knows what it is, yeah, we got some correct answers in the chat. This is a nerve, and it's an ulnar nerve. We know it's the ulnar nerve because we're at the level of the elbow, because we've already orientated ourselves to that, and we know that the ulnar nerve goes through, passes by the ulnar, quite superficial at that point in the elbow. And that's the cubital tunnel. Okay, as promised, the normal pediatric elbow. I just wanted to throw in the ossification centers of the pediatric elbow because they're important clinically, and you could well be asked about these. So just making sure that you remember what's articulating with what. So you've got the capitellum, the radial head, and do label it as ossification center. I think it's important if they've got ossification centers and it's not sort of fused bone as in an adult skeleton, I think it's important to identify that you can recognize that this is a pediatric radiograph. Internal condyle, clear, olecranon, and then they would have an external condyle here, but this patient's too young, so they haven't got that yet. But just find a way to remember those. Crytol is what I use, and that's just one of the ways that you can remember it. But for time, we will move on. This slide is busy on purpose. It's to show you just how complicated the forearm can be, and there are so many different small muscles of the forearm that I think it would be quite challenging for them to ask you to label them. If you have something like this and you want to try to get those extra marks, that's fine. You can spend the time to learn it. But if it were me, I personally would focus my attention on other bits of anatomy, because I think it's just too hard to isolate the anatomy without being able to scroll through. Okay, I'm going to move swiftly on to the wrist. Again, it's about just taking a step back and finding out where are we. So this has the classic appearance of the extensor tendons of the wrist. They're nicely spread out around the back of what we can see are the carpal bones. And then you have more bunched tendons, and these are the flexor tendons. So this is the appearance of the carpal tunnel, essentially. Until you see it, it's not something that you would assume. So it's good to just see an example of each of one of these bits of anatomy, and then it helps to orientate and you can apply the principles. It's MRI, so we know that these are tendons because they are black. And here we know this is tendon because it's black. Just wanted to point out, again, we've got a nerve here, so you can see that kind of peppered appearance, lots of dots. So that's your nerve in the carpal tunnel, which we will come on to. Does anyone know what this is pointing to, though? This structure is a thick black line. It's not one of the tendons, I'll tell you that. Yeah, got some correct answers. So that's the flexor retinaculum, and it comes over the top of those flexor tendons in the carpal tunnel. Now that nerve, if anyone knows which nerve I'm pointing to, a lot of us know in theory, or some of us will know in theory what goes through the carpal tunnel, but it's very different when you actually see these structures. So this is the median nerve. So you've seen it in the chat. You guys are smashing it. Just a quick diagram to show you what's in the carpal tunnel. I wouldn't spend too long trying to be able to say, oh, this is a flexor digitorum superficialis tendon and this is flexor pollicis longus in the carpal tunnel. I think it would be quite harsh to ask you to specify that. The one thing that they might ask you to specify is the nerve, because there's one big classic nerve that goes through it. So it's worth just nailing down that anatomy, but I wouldn't spend too much time trying to work out all the other bits. It's good to know what to know as well as what not to know, I think, for exam technique. And this is just showing you how all of these structures interact together. So here we have the distal ulna and we got the distal radius. And then I'm just scrolling up. This is the palmar side. So where you've got your flexor tendons and you can see the nerve there. And then you've got your extensor side here, all your extensor tendon. Oh, yeah, my mouse might not show, but this is the extensor side. So you've got all your extensor tendons here, and these are the flexor tendons on the palmar or volar side. And then when you're looking at the carpal bones in the axial plane like this, it's good to look for some landmarks. And some of those include the hook of hamate. That can help you orientate. And if you scroll through and just get used to looking at all of the different carpal bones, that if you look at the pisiform or pisiform in the lateral view, for example, you can see that it sticks out slightly anterior. So it's more on the palmar side, and that can help you as well. The scaphoid points forward, and it's just finding little tricks for the exam that give you landmarks to look for, so you have an approach and a system, so you don't panic when you're faced with these images. Okay, oh. So that one's given it away, but I have just spoken about this. So a classic appearance, the hook of the hamate bone. This is a really useful structure to know about clinically. If anyone knows it, pop it in the chat. I'll give you a clue in that we can orientate to the distal radius. And we've got the ulna, got the flexor tendons coming in here and some extensor tendons around here. Okay, I'm going to keep going. So this is Lister's tubercle, and it just sits on the back of the radius, and it's a really useful way of knowing which extensor compartment you're looking at. I don't think you need to go into this detail for your anatomy in terms of all the extensor compartments, but just so you know, there are 6 compartments, starting with number 1, number 2, and number 3 just sits this side on that ulnar side of Lister's tubercle, and it can be a really nice landmark to help with knowing which extensor tendons you're looking at. Again, this just shows your extensor tendons. So compartment 1, 2, 3, 4, 5, and 6. Hopefully there's not too much of a delay when I was doing that. But if there was, we've got a helpful coloured diagram here to show it. I wouldn't worry about learning each of these. In theory, if they wanted to give you a tricky question, they could ask you, say, extensor pollicis longus, because at Lister's tubercle, I don't think they'd ask you at any other point in the wrist, but at Lister's tubercle, it always sits on the ulnar side. So it's just medial to Lister's tubercle. So just trying to look out for those tendons that could be asked about if they have a classic position. But for example, extensor pollicis longus will also cross over at different parts in the wrist. So I wouldn't spend the time learning the different extensor tendons at other parts of the wrist. I think that would be really tricky, and you'd spend more time learning than gaining marks. So if you're going to learn any of them, learn the ones that are identifiable, probably at the level of Lister's tubercle. I'm not going to go into all of the carpal bones just because we don't have time to do all of the anatomy of the entire body in terms of MSK in an hour and a half. But just a reminder, make sure you've got a way of remembering what carpal bones what. There are lots of rhymes out there. Pick the one that you prefer, and make sure you don't forget kind of anatomy. And then again, thinking about if you're looking in the lateral view, which bit's going to stick out anterior, like the pisiform and the scaphoid, and things that will help orientate you. And then it's just nice to, if you're in work and you're reporting, say, a CT wrist or an MRI wrist, if you just scroll through, making sure that if you stop on any part of the scan, can you label, for example, could you label that bone, or could you label this one? This is actually part of the scaphoid, and you can see that's it continuing there. So if you do get a lateral, like I said, if you've got an anterior part, a bone that seems quite anterior, if it's by the thumb, that's going to be the scaphoid. On the other side, got the pisiform. Little tricks like that. Okay. Last bit for me, I'm going to talk about the spine quickly. So, normal anatomy. This is just a reminder about the number of vertebrae and the number of nerves, because it's important that if you can tell the level, make sure you are saying what level nerve or vertebra body or whatever the labeling you've got. So the number of vertebrae in the cervical spine is 7, but the number of nerves is 8. So that means that in terms of your exiting nerves, if it's in the cervical spine, then the nerve root will come out above the level that you're at. So for example, the C4 nerve root will come out between C3 and C4. If you're in the thoracic or lumbar spine, then it's going to be below. So for example, the L4 nerve root is going to come out between L4 and L5. A few other tips on specific examples of questions that came up quite a lot for me in my past questions. This came up a fair bit, and if anyone knows what I'm pointing to, do put it in the chat. But this is where I think you can pick up the extra mark by being specific and right. But make sure you are specific and right and not specific and wrong. So we've got C2 in the chat, body of C2. I personally like body of C2, and that's what I've put. C2 is not incorrect in any way, shape or form, but I think if they're specifically pointing to the body, then label it the body of C2 if you know that's what it is, because the odontoid peg is also C2, but we're not pointing to the odontoid peg. I suppose the worst thing you could do is put odontoid peg and then lose 2 marks, so it's just making sure that you can differentiate between those parts of the vertebra. Another one that came up for me in practice questions was this arrow. So if you know this one, then let us know what you think it is. Again, it's about being specific and correct. I'm going to keep going just for time. So I think there's a bit of a lag, but this is the anterior. Yeah, we've got some answers. Yeah, plenty of anterior arch of C1. Perfect. So everyone's been really specific and correct. Nice. And this is pointing to the bone here. And this one I bring up because it almost is like a paired structure, I suppose, and that this is the right lateral mass of C1. If the arrow points to a lateral mass, and you can see the other lateral mass, make sure you're saying which one, which side, even if they haven't labeled sides or anything. Like here, fine, we've got left side, but I think you should be putting what side. Another question that I know quite a few people found tricky when I was revising is this, and it's just looking exactly where that arrow is pointing. So here we're pointing to the black, the space between the 2 bones, above and below it. So here specifically, it's a C4-5 facet joint. It's not the articular process, it's not spinous process, it's the joint between it, specifically pointing at the black. And yeah, we've got a correct answer in the group. Perfect. This looks like it's exactly the same question, but it's not. I hope you can see that this is actually pointing to the bone, and it's pointing to the bone in the inferior part of the vertebra there. So we're at C4. So this is the inferior articular process of C4, because we're specifically pointing at the bone. And another point to make, just exam technique, is don't try to side these. If I were you, I think it's impossible to say what side that we're pointing at, but do put the level, because I can clearly see that this is C2 here. So I know that this is C3, and I know that this is C4. If you get cervical spines, they also like to ask about other structures that aren't MSK. So I thought I'd just throw some in today, just to keep you on your toes, make sure you're thinking outside the box. Here you can see this is the trachea. Yes, so we got some correct answers there. Perfect. Slightly trickier. Anyone know what this is pointing to? Another one in all the practice books. Perfect. The epiglottis. Well done. These are tricky, the spinal ligaments, but this diagram quite nicely highlights a lot of them, and you wouldn't need to know any more than this. In fact, I think this goes over a few too many. I would certainly try to recognize the anterior longitudinal ligament, and it's easier seen, I think, in the sagittal plane, but don't forget to try looking at different MRIs when you're at work and things, to see if you can see it in the axial plane, and if you can see it in the coronal or in all other planes, but I think that'll be trickier. So sagittal is good for that. And then you've got posterior longitudinal ligament. Here you've got ligamentum flavum, and then you've got your supraspinous ligament that goes around the back. I think those are probably the main ones to learn. And if you want to go into the others and recognize them, that's great. I won't go into them today. Another slightly left field question, I suppose. Let's orientate ourselves. We've got an MRI. We can see that this is the shape of the vertebra, and we can see the spinal cord in the canal. On the right-hand side, we've got the arrow, and it's pointing at this black bit here, and we can see there's another joint that's on the same side, that looks the same, but it's on the opposite side. You can see that it's joining with this bone that keeps going round here, and it's posterior. So this is the right costovertebral joint. So once you've recognized that you're at the vertebra and you've got a rib, join the two words together, you've got costovertebral joint. A lot of anatomy you can work out and combine the words, whatever you're looking at, and you might get the 2 marks for it. This one I just threw in because it came up a lot in my practice questions. Again, I think it's one that's favoured in the books. So this is the sacral promontory. Another slightly odd question, but you can get thrown these things. What is this structure, you might be thinking? Well, it's the same kind of intensity as this, and these are all your sort of muscles of the back, but this one's anterior, it's more within the abdomen. So this is your psoas muscle, and I will show you that because it's just nice to follow on an actual MRI scan. You can see it goes up here and then it comes down. Cool. So you can see superiorly, you can see it up here, and then as we scroll through, comes down towards the pelvis down here, but we haven't got all of it because you don't normally get all of it on the lumbar spine MR. Okay, and then moving swiftly on, I've labelled something, a structure there. If you haven't reported many MR spines, it's good just to get your eye in. This is where the nerve comes out. So this is the exit foramen. It's kind of a keyhole shape, and you've got the vertebral body anterior here, and then you've got the posterior elements of the vertebra there. And if you see this, we know that this looks like S1. We know that this looks like L5. I think that it's fair enough to say that this is L4, and therefore you've got the exiting nerve root coming out between L4 and L5. And so that's going to be your L4 exiting nerve root. I put this one in just because there are so many muscles at the back that you could spend a lot of time learning. I personally chose to opt for paraspinal muscle and to side it. You could go into more detail, but in terms of prioritizing my time, I opted to just learn left paraspinal muscle, and I didn't go into more detail than that. Another bit that people found tricky is knowing about the articular facets and which is which when you've got this kind of almost a hamburger shape here. The inferior articular facet is always posterior, and the superior articular facet is always anterior. And you might get asked it on an axial image, so that's harder to work out which is which. But if I show you this, I think it makes it a lot clearer, because you can see there that the superior articular facet it's always falling anterior, all of these. And then the inferior articular facet is always posterior. So I think that helps to kind of imagine that 3D orientation, because when you're faced with one slice and you're just asked to say, is this superior or inferior? I think that can be really hard. And this is just to flag pars interarticularis. So you've got your inferior articular facet and your superior one. The bony bit between them is the pars interarticularis. And I think that can be hard to understand sometimes. So it can be tricky to sort of orientate yourself there. But if you ever hear this phrase, that's what they're referring to. It's the bony bit between the two articular facets. And this is just to show the nerve roots primarily. You've got transiting nerve roots going through the spinal canal, and then you've got your exiting nerve roots when they're exiting out of the neural foramen there. So just discerning whether you're looking at a transiting nerve root or an exiting nerve root is also important. For time, I'm just going to show you the answers to these questions because there's so much anatomy to get through. I think it's important to distinguish between caudal equina and the spinal cord itself. So this is the caudal equina because there are nerve roots, separate nerve roots that you can see. For example, you can see the couple of nerve roots here that are transiting and about to exit lower down. But all this cluster of nerves, that's the cauda equina, versus the spinal cord, which is more sort of solid. You can see all of the nerves are in there together. Another tricky one is this area just posterior to the spinal canal. We've got some bright signal, but it's not as bright as CSF. A lot of people might think, oh, that's just CSF kind of flowing into that little recess there. But actually, this is epidural fat. And they do like to ask this, and they like to ask it in the sagittal plane as well. So this is sagittal view of the epidural fat. Okay, so I'm sorry that's been a whistle-stop tour. There's a lot to get through, but I know this is being recorded, so hopefully you'll be able to go back and look at some of the ones that we went over a bit more quickly and really get your head around those. But now I'm going to pass on to David, and he's going to take you through some more anatomy.
Okay, I don't know if the plan was for a little break now. I don't know if the bosses want us to take just like a 1 minute refreshment break or not. With the next half, I was very offended to see that Karen used some not MSK questions there. It's hurt me deeply. So there'll be none of that with this next section. So it feels a lot of people would dread this, but it's something which does come up from time to time, and especially in the practice questions. I'm not going to go through on my slides every single thing as a as a question, but I think we're keeping an eye on their chat as well. So if we start with this here, I just want people to name a tendon, and just note that it says name a tendon. It doesn't say name the tendons plural. It just says name a tendon, which attaches to this point here. I'll just keep a little eye out. So this is your left greater trochanter. And so you've got two, yeah, lovely, got some correct answers there. So you could say gluteus minimus, could say gluteus medius, and it said name a tendon, so it's inferred that this is a tendon, so very good. And make sure you're saying left in this circumstance. You would drop a mark if you didn't say left. This structure here, name a tendon that attaches here. So this is your right ischial tuberosity. You've got a number of things which you could say. The easiest ones are your hamstring tendons attached here. So you could say, so if we're being really, really pedantic, then the conjoint tendon is formed of the biceps femoris tendon and the semitendinosus. So you could say conjoint tendon or semimembranosus tendons are the two hamstring tendons which attach there. I think if you said hamstring tendon, right hamstring tendons, I don't think that they're going to drop your mark for that because you demonstrated that you understand which anatomy attaches there. What attaches to the lesser trochanter? The right lesser trochanter. Yeah, lovely. So we've got iliopsoas tendon, lovely. And just one thing which I think this is actually really tricky is just nailing down where the ASIS and AIIS are. So I think when I was looking first, I always thought this was the AIIS, the anterior inferior iliac spine, but it's actually slightly higher up here. You can see this kind of bulge. I thought this was quite a nice example of this. We'll go over it just a little bit later. So what attaches to the AIIS? So we've got, yeah, very good. So rectus femoris tendon, and the ASIS is the sartorius tendon, right? And I just thought I'd zoom in on that. So I get the impression here, or this is one of the sort of muscular attachments or tendinous attachments, I should say. So right, this is the left side now. This is the left sartorius, sorry, rectus femoris tendon, just come in here. I've sort of highlighted them here. So you can see that there is a bit of soft tissue joining, and a little bit of soft tissue coming up here and joining into the ASIS up here. Just make sure, so this actually isn't the AIIS. This is a lateral margin of the acetabulum. Nice. We get straight into some MRI of the hip, which again, I found this really tricky. MRI of the pelvis and hip. I wouldn't be surprised if people are finding this difficult. So some of these will be all right. I hope some of these will be harder. What do people think this muscle here is? We'll go for the hardest muscle on the screen. Any answers? So this is the right. Again, I think you could probably just about say this is right as opposed to left here. So this is the right piriformis muscle. This big muscle back here is, so we're sort of trying to orientate ourselves now. We know that, well, we think we're in the pelvis. We can see a bit of bowel here. It's got a little bit of bladder anteriorly. You've got the abdominis muscles anteriorly here, rectus abdominis. So we're thinking, okay, we're in the pelvis. This is a big chunky muscle at the back here, which people often will come across a bit more during the past questions. This is the gluteus maximus muscle. And so when you're quite superior, and we're thinking we're superior because we've got this other structure here, which is dark rimmed, so bone. So we've got iliac crest up here, and we're thinking we're quite high up, anterior to the gluteus maximus, and medial, this is the piriformis muscle. And so we've already said this is a gluteus maximus. So people just want to comment what these other two muscles are here. So we've got one of the muscle here and another muscle here. These last two here, which are they? Yeah, so we've got gluteus maximus at the back, and then just anterior to gluteus maximus. Yeah, lovely. Yeah, yeah, cool. So medius anterior to just anterior to maximus, and then minimus even further anterior. I always think of the iliac bone, the iliac wing, and I sort of think about this being sandwiched between the gluteus minimus and the iliacus muscle, and that's quite a useful way of just knowing exactly which muscle this is. If you can see the gluteus minimus on one side here, then on the other side you've got the iliacus muscle. We're a little bit lower down now. We know that we're lower down. We've got the structure here between the two pubic bones. We've got another bone here. So we're just going to go through a few of these. I'm going to start centrally here and try to work our way around. So we've come a bit lower down. Does anyone know what this structure here is? In the meantime, we'll go through some of the other sort of localizing anatomy. Yeah, very nice, very nice. Yeah, perfect. So we've got pectineus muscle. So this, I always think again, so at this level, you've got to orientate yourself to the level first, because at other levels, other muscles can look quite similar, but we've got the obturator foramen here. And you can tell that because you've got the pubis here and you've got the ischial tuberosity down here. So we're at the level of the obturator foramen. The most anterior muscle there is the pectineus. I think if pectoralis muscle sits at the front, pectineus muscle sits at the front. That was my way of remembering it. And then because we've got the obturator foramen, these two muscles here on the outside and the inside of the obturator foramen. So we've got pectineus, we've got the communication between the two bones anteriorly here, so pubic symphysis, obturator externus and internus, the ischial tuberosity. This big muscle at the back again, which we know is the gluteus maximus. Yeah, lovely. So I think people are getting these. So we're not quite low enough down to be at the adductor muscles yet. We'll come to that. There's another muscle here, which is, you can't quite see it snaking through, but sort of between the ischial tuberosity and coming around towards the femur here, which is one of the harder muscles again. So this is the quadratus femoris muscle. Again, that's a really tough one. Pectineus is tough. Quadratus femoris, those are tough muscles. And then coming round anteriorly, we've got a few more muscles here. Some of these have quite characteristic appearances. So if we go from left to right, people just want to chuck out any of these muscles, starting 1, 2, and 3. So this is the first muscle here, is the tensor fasciae lata. Very nice. So people are getting these right. This is tough. Fine. Yeah. Okay. So perfect. So the sartorius is the most anterior muscle here. We've then got this muscle here. It's got this odd black line through it. So we've talked about the tendon previously. Karen's talked about the tendon within the muscle. So we talk about a myotendinous junction. That's just the way that the muscle and the tendon attach together within this muscle. So this is the rectus femoris muscle. It's got that really characteristic black line down the center of it. It's a bit of an odd configuration with its myotendinous junction. So that's quite characteristic. And lovely. That's very good, guys. Okay, so again, most anterior muscle, we've got this black line through this muscle, and just lateral to that, we've got another muscle. So these are the same three over here. So we've got the tensor fasciae lata, the rectus femoris, and the sartorius slightly lower down. How about these three muscles coming down here, though? Yeah, lovely. So these are the adductors. And does anyone have any way of remembering the adductors? I remember, thinking this is pretty tricky trying to remember exactly what's what with the adductors. So the way I remember it is longus. So it's longus brevis magnus, and I am not a cricketer, but I'm aware of the term leg before wicket, and we decided that leg before micket was the perfect way of remembering it. So if you have played any cricket or are aware of it, then the ball was traveling from front to back for that to take place, is my loose understanding of cricket. So yeah, so leg before micket, longus brevis magnus, and we're a bit lower down again now, so we actually can't see that obturator foramen at all. We've dropped off the bottom of the ischial tuberosity. We've just got the femur. We've got quadratus femoris again at the back here, which is anterior and medial relative to the gluteus maximus here. And we've just got the beginnings of another big anterior muscle coming in here. Does anyone think they could have a guess at what this is here? So we're anterior lateral within the thigh. Yeah, lovely. Perfect. Vastus lateralis. Lovely. And we've said tensor fasciae lata and rectus femoris. Very good. Again, you look at this, think, oh my goodness, this is tricky. But we've got big bone here, dark peripherally. So we know that's a bone. We've got lots of muscles around it. Quite characteristic appearance, that of the iliac crest here. So we've got a couple of muscles medial to that, a couple of muscles lateral. This is external to the body, this blackness here. So remember we talked about something sandwiching this iliac wing here. Does anyone remember which those two were? Yeah, perfect. So we've got iliacus medially here. And then iliacus forms together with another muscle here and travels inferiorly. So that other muscle is the psoas muscle. So they're going to become the iliopsoas tendon to come further down. And yeah, lovely. That's really good. Yeah, really good. Well done, guys. And gluteus minimus muscle again is on the lateral aspect of the iliac wing. And then the muscle which is even more lateral than the gluteus minimus here. So this is the gluteus medius. So at this level, this is sort of slightly too anterior to get the maximus in there. So yeah, lovely, lovely, well done. So I think this anatomy is tough. I think that we're showing you some hard stuff here. We're at the level at the hip joint now. And again, this is just the gluteus minimus and gluteus medius coming down towards their insertion here onto the greater tuberosity. Very good. A muscle, big muscle within the lateral aspect of the thigh. If you were to hazard a guess as to what that is, does anyone want to hazard a quick guess? I say guess, a thoroughly educated guess, or a knowledgeable. Yeah, lovely. Vastus lateralis, spot on, spot on. So I think with some of these, you can sort of try to logic your way through. This is an absolutely brutal question, I think. But again, if you see these kind of things, you've got to try to work out what could this be. People feel free to start chucking answers out if you think you might know. But I would look at this and think, okay, so I've got, I'm in the pelvis, I can see the hip, and I can see probably around the level of the obturator foramen there. Yeah, that's not a bad shout at all. So this is really tricky. We're around the level of the obturator foramen. You've got a muscle just medial to it and a muscle just lateral to it. And I think this is in continuity with that. So this is actually the obturator externus muscle. That would be absolutely as hard as anyone would ever go. Maybe too hard for the exam, I think that. But that's really just a case of sort of trying to work your way around. And a couple of knot muscles. People just want to put in the chat what they think these two structures might be. Yeah, so the fovea is kind of that sort of dimple there and the femoral head, yeah. And we've got if I point to the actual structure contained within that there. And what's the other? Yeah, ligamentum teres. Perfect. Yeah, lovely. And we've got the acetabular labrum over the top here. Okay, we're coming down the leg a little bit now. So we think, Karen was talking about arm versus leg earlier. We can't see any of the body here. Also, if we think in the arm, could this be an odd presentation of an arm? I don't think that we would say that because, in the back here, we've got 4 separate muscles, so it can't be triceps. It doesn't look like biceps either. So this is in the leg. We'll just work our way around. So these 4 muscles form the quadriceps. So there are 4 muscles that we need to know of then. We start most anterior and the small muscle at this level. Sorry, I have to close and open the chat every time. Perfect. Rectus femoris. And then the big muscle here. So is this medial or is this lateral? We're just going to go through a couple of ways of trying to work that out, but we'll see what people put. So what muscle is this? Because, you can either say this is the 50-50 torn cast. Yeah, perfect. Vastus medialis. This is medialis. The reason why I would say that we've got this classic teardrop shaped muscle here, which people feel free to just chuck these in the group. And we've got another muscle just behind it here. So vastus medialis sits just anterior to the tear-shaped muscle, which is sartorius. Lovely. And we've also got some more of the hamstring tendons coming down. So we've got, sorry, the adductor magnus is the biggest muscle. It's the only adductor which reaches this far down into the thigh. And then we've got the gracilis, which is the other smaller muscle behind the sartorius. And then we've got our 3 hamstring muscles. And the most medial is semimembranosus for medial. And we've got semitendinosus sits next to it. And the most lateral is biceps femoris. And then we've got vastus lateralis, and then finishing off the vastus muscles, vastus intermedius. So I think with these ones, these are really easy to take a quick look at and think, just you sort of jump into them and then end up putting vastus lateralis as when you meet medialis. It's just worth taking a moment, step back, find the structures which you know are medial or lateral, and work from there. This is just to quickly show you again. I thought it was quite a nice representation. So we're at the level here of the obturator foramen. So we've got the right obturator internus, obturator externus, and pectineus at this level. So level of the obturator, internus, externus, pectineus. And we come down further, so we're just at the level of the ischial tuberosity here. It's quite hard to really appreciate those differences between the muscles, but as I scroll through, you might be able to see the lines between these muscles. So here we've got our adductor muscle, so leg before micket, so longus, brevis, magnus. We've got some of those same things represented on this MR here, but I just wanted to show you again, just to remind you, you've got the so we've got the tensor fascia lata here muscle, and then rectus femoris muscle with its odd myotendinous junction, and sartorius sitting most anteriorly. And we can show you coming further down the leg again, we've got that sartorius, which is traveling more medially, gracilis, which is a medial structure, that adductor magnus coming down and then disappearing, and then into the knee. So medial versus lateral knee. Again, you could look at this and think it's tough to say which is medial and which is lateral. So I'm just going to go through a couple of different ways which I use at this level to determine. So I would say that the patella sometimes points towards lateral. Some of these aren't infallible, so you might need to look for a couple of different things. You can look for the iliotibial band, which is an anterolateral structure. And also just make a note of the fact that there are more muscles and tendons medially within the posterior knee. So I was saying that the patella points laterally, but I'm not really convinced in this one that I could convince myself that's the case. I tried to choose a case where actually it's quite a symmetrical patella, so I don't think that helps us unlock it. But do people just want to say which structure this is here, which I've pointed to with an arrow? So we're talking about this structure. Yeah, perfect. So iliotibial band. So I've said the iliotibial band is a lateral structure. So now you've almost unlocked the knee as it is by just determining which is lateral, which is medial. And then we've got the lateral facet of the patella, or the lateral aspect of the patella. As we come on to the other side, we've got our medial structures. We'll start with these structures back here. Or this is just towards the end here. This is the tear-shaped muscle and 2 tendons here. Do people know what these 3 are together? Or not together? People just want to say which 3 structures those are. So in the medial posterior. Yeah, exactly. Yeah, perfect. So they form the pes anterinus. People have different ways of remembering them. You say grace before T is one way. So sartorius, gracilis. So sartorius muscle, this is at this stage. Gracilis tendon and semitendinosus tendon. So people remember it as Sargent, SGT, or say grace before T, whichever way works for you. And then this other bigger muscle back here, just anterior to the semitendinosus, is your semimembranosus. This here is, does anyone know which muscle this is? I think this is a tougher one at this level. Yeah, lovely. Well done, guys. It's really good. It's got good ways of remembering these at this level. So just going for this muscle, which is anterior to the semimembranosus. Yeah, gastrocnemius. So perfect. We said medial head of gastrocnemius. So we're on the medial aspect of the knee here. So yeah, that's spot on, well done. And then this muscle here, this is another of the hamstrings, and it's the lateral hamstring. So this is your biceps femoris muscle. So from a point where you could look at it and think, I don't know what's medial, I don't know what's lateral, you've identified a lateral structure in the iliotibial band. You've identified you've got more muscles and tendons in the medial aspect of the posterior knee, so you know where you are, and you can work your way around that picture. Good work. And again, another one where I think it's quite hard. See, when you've got a tibia and fibula, you think that's fine, that's easy. But at this level, you don't have that. So we're a little bit higher up actually here. We start at the top. What structure? Great. What structure is this here? Yeah, perfect. Quadriceps tendon. And then if we go for medial or lateral structures, I would say there are more things on the medial aspect here, although that might be slightly hard to say. This muscle here is bigger, which would be a giveaway for me. So I would say there are more muscles overall on this side and tendons. I would say that this muscle's bigger. So does anyone know, if I say go for this side of the knee, is this medial or lateral? Yeah, perfect. Spot on. So vastus medialis from the medial aspect of the knee, and then you can go through sartorius gracilis, semitendinosus again, semimembranosus sat in front of it, biceps femoris muscle, and vastus lateralis. So yeah, really good. This is at the level of the knee again. So people call this, you're not going to be marked down for saying this is the patella tendon or the patella ligament. That various people say various things about that. You won't lose a mark for saying either. I just want to quickly go through these two structures. These are important. Does anyone know what structure this is here? Yeah, perfect. Spot on. ACL. And the way that I would, so you've got to try to come up again with another way of remembering that. So I would be looking back here and looking for these. You've got the sartorius gracilis and semitendinosus back here. So I'd be using that to unlock the fact that this is the medial aspect. The ACL, I always think of it as a hand traveling into your pocket. So the ACL starts superior, posterior, and lateral, and travels in an anterior, inferior, and medial direction. Okay, so this is traveling from posterolateral to anteromedial, so it must be the ACL. And then the PCL does the opposite, and therefore, so once you've identified one, you can work out the other. So we worked out this is medial, so this is the medial collateral ligament. It's another dark structure. We've said that we've worked out the ACL, and therefore the PCL, which sits more posteriorly there. We've got sartorius gracilis semitendinosus, semimembranosus tendon at this level. And now we're a bit lower down. So we've already identified higher up that this is the medial head of gastrocnemius, and this is the lateral head of gastrocnemius. How about these three structures here? We're going through a few of these a bit quicker, guys, just because I'm very conscious of the time. We're going to be finishing a little bit late, but I just want to try to get through as much as we can. So does anyone know what any of these three structures are? Let's chuck anything out into the chat. Yeah, perfect. So this most medial one here is, sorry, well, yeah, the one sat in the groove here is the popliteus tendon, and that's in the popliteus groove. So that's a lateral structure. It's another lateralizing structure. You could use that to identify which is medial and lateral. This is the lateral collateral ligament or fibular collateral ligament if you want to, and this is just the biceps tendon, biceps muscle and tendon coming down there. Very good. A couple of lower down. We've got the gastrocnemius. This is the medial and lateral aspect of the gastrocnemius. The soleus arises just a touch lower, be just a tiny bit lower than this. It arises from the fibular head, though. Does anyone know this? Now, this would be a really brutal question to ask. There's a tiny little muscle in here. Does anyone know what muscle that is? This is getting to absolutely crazy, crazy difficult levels. Yes, perfect. So plantaris muscle, spot on. And then this muscle here started more laterally, is traveling down. It started in that popliteus groove, traveling down. So this is the popliteus muscle. Yeah, nice. This is just to quickly show you, to try to convince you that we have got the plantaris muscle here. So it's arising just deep to the sort of lateral head of the gastrocnemius, and it travels more medially here. And I think I've got another case which is even nicer. So we've got this is the plantaris here. That's quite a nice demonstration of it on this T1 sequence here. So you can see it coming down and traveling more medially. And you can also see the soleus on this patient sort of arising from the fibular head here. So you've got gastrocnemius medial, lateral heads, and soleus just coming in here deep to those gastroc muscles. Okay, just in the interest of time, we'll go through these ones. So is this medial or lateral? I just want people to pop in the group. Is this a medial or lateral sagittal view of the knee? And feel free to chuck out any answers if you would like to. Good work on the plantaris there, guys. That was a really tough question. Yeah, spot on. Medial. So how do we know it's medial? We've got the classic sort of golf tee shape of the tibia here. That's the easiest way of remembering it. So we've got some articular cartilage. You can say medial femoral condyle articular cartilage. This is a black structure within the knee, which looks like a bow tie. So it's your meniscus. It's the posterior aspect of the meniscus. You've got all the muscles here. So it's posterior medial meniscus, or posterior horn of medial meniscus, and then medial tibial plateau. So that's that beautiful. I'd say that's as good as diagram films these days. Golf tee. Okay, and this is just to try to demonstrate lateral. So I've tried to not put the fibular head here, but that's quite a nice lateralizing structure. People talk about the fact that it looks a bit more like a walking stick, the lateral aspect of the tibia. So that's one way that you can look for to decide whether that's medial or lateral. So here we've got the lateral horn of the anterior horn of the lateral meniscus. There are 3 structures here. These are all fat pads. Do people just want to say which 3 fat pads these are? I suspect you may have come across that one. You may not be aware of the fact that there are these other 2 here, potentially. Yep, so we've got suprapatellar fat pad, very good. Is that above? And then we've got the infrapatellar, is this big chunky one, also known as Hoffer's fat pad. And yeah, perfect. And this last one here, it just sits anterior to the femur, so it's the prefemoral fat pad. So we've got Hoffer's or infrapatellar, suprapatellar, and prefemoral. Just worthwhile noting. It's also quite nice when you see your X-rays. This is where the fluid's sitting when your joint effusions. So that's what's being pulled apart when you look at those lateral views on your knee X-rays. And again, just trying to decide whether this is medial or lateral. This looks more like a walking stick, so this is going to be a more lateral view. So posterior within the knee here, got lateral gastrocnemius. The muscle which is sat just deep to that is your plantaris, and then this other muscle here, just hugging the posterior lateral aspect of the tibia, is your popliteus muscle. Just the main one I want you to take away is this. What structure is this here? Okay, so we're this time we're going from the medial aspect. I think to me this is running in a medial to lateral trajectory as opposed to lateral to medial. So it's not the hand in the pocket. So it's the posterior collateral ligament. And then we've got the fibular head here, so we know this is lateral. And then you can say, because we're quite far posterior, I to be honest, at this level, would just say medial meniscus. I think that would be perfectly legitimate. If you want to, you can say it's the posterior horn, but if that's necessary. And again, just trying to demonstrate the muscle coming down here, wrapping around the posterior aspect of the tibia is the popliteus muscle. Okay, so this is the ACL. So I'm just trying to work out a way of deciding whether this is medial or lateral. It looks relatively symmetrical, but we've got this black structure coming down the side here. This is our ITV. So this is what's giving it away as a lateral structure. I don't know if I can convince myself that's a fibular head coming in there. I think I'd find that difficult to absolutely convince myself, but that is what's coming in here. So we've got a structure which is coming a bit more from lateral to medial. So this is ACL compared with that. So medial to lateral, PCL. Lateral to medial, ACL.
And again, I'm just going to quickly go through these. So this is just to demonstrate, this is the PCL coming here from medial to lateral, and ACL is coming a bit more from lateral to medial. Okay, ankle, and then you guys are all done. So again, looking at these, you think, oh, this is way too much information. There's no way I can unlock this. There's just a couple of things that you can look for to try to decide which is medial and which is lateral. I think it's probably easiest, to my mind, it's easiest to look at the posterior aspects of the foot to try to identify a couple of bits there. So if we start, we'll start at the front. Does anyone know what this structure here is? So we'll do these. Yeah, spot on. So tibialis anterior. So if you're saying that's tibialis anterior, you've said that that's a medial structure. So I absolutely agree. The reason why I'd say that's medial, it's the biggest tendon in your foot. If you feel your foot, the medial aspect, the biggest tendon is the tibialis anterior, which is sat there. And then on the posterior aspect of the ankle here, on the medial aspect, we've got 3 tendons here. On the lateral aspect, we've just got 2. And that's the way which I would use to unlock that part of the knee, the ankle. So we've got tibialis anterior, these other 2 structures here. People just want to pop down what they think those 2 are. Yeah, spot on. So we've got the extensor hallucis longus tendon. I'll say that that's pointing at the tendon there because it's black. And then we've got the extensor digitorum longus tendon. And so people talk about this being TED. So at the anterior aspect, you've got TED, so tibialis anterior extensor, extensor hallucis, and then extensor digitorum. I mean, it doesn't really work because there's no H in it, but anyway, people talk about TED, so tibialis anterior, and then you know that the most lateral is digitorum longus. This bone here is the talus just coming in. And so we've already said that this is lateral and this is medial. So this is your lateral malleolus. Behind here, I want people just want to have a go at which structure this one here is. So this is getting tough now. So we're over the lateral aspect of the ankle and the posterior aspect. Spot on, absolutely spot on. Peroneus longus tendon. Make sure you're saying tendon because it's obviously attached to a muscle higher up. So I would say tendon at that level. I would say that this one, to be fair, that's maybe a slightly dubious area, but if we say it's pointed to the grade and this is pointed to the muscle here. So the peroneus longus, it basically sits at a slightly lateral and then scoops underneath the peroneus brevis tendon as we come more inferiorly. This here, right at the back, is the Achilles. But what's this muscle just sat just anterior to the Achilles here? Yeah, perfect. So you've got soleus muscle, which is going to join in onto the Achilles there. And then just anterior to that, now we're looking at these medial structures. So these sort of come together. People talk about these tendons and this muscle here coming together. So if we start most medially here, what structure is this? Yeah, perfect. So, and people probably know this is Tom, Dick, and Harry, or Tom, Dick, and very nervous Harry. So we've got a nervovascular bundle here. So you've got tibial nerve, your posterior tibial artery, and veins there. So Tom, so this is your flexors now. Your flexors travel underneath the foot and help you to flex your toes. So this is your tibialis flexor. Apologies. This is your flexor tibialis posterior. Tibialis posterior. Sorry, apologies. Tibialis posterior tendon, and then we've got our flexor tendons here. So flexor digitorum longus and flexor hallucis longus. So Tom here, Dick, and Harry, and then just medial malleolus over on the medial aspect. So there's a huge amount of anatomy on there. I think you guys do seem to be nailing that, to be fair. Just to show you in a slightly different view, just want to show you these 2 tendons again. So we're over the lateral aspect. You can tell it's lateral because you've got the fibula, this aspect of the fibula, which is this most superior one. Yep, spot on. Well done. That's really good, guys. Yeah, so peroneus brevis. So the peroneus brevis sort of held as it comes underneath, the longer sort of sits underneath it. Really good. So this other structure, which is more inferior, is the longus tendon. Very good. And how about this? I just wanted to show you that you could look at the medial aspect. There's a couple of things which show you this is medial. I've got one arrow to a bone here. So does anyone know what specifically this is pointing to here? There's a bit of bone. You might see it more classically on your X-ray, so it's slightly odd thing to see. Yeah, spot on. Sus tentaculum tali, sort of medial aspect of the calcaneus, and then we've got 3 tendons here. We're over on the medial aspect. You can say that because we've got the sus tentaculum tali. You can also see that this is the medial malleolus. So we're medial structures. They're dark, and so they're tendons. So these are your Tom, Dick, and Harry again, and relatively speaking, from medial to lateral. So tibialis posterior at the top, digitorum and hallucis longus. I think people we've seen this one before. So this is the Achilles, but what's sitting just anterior to the Achilles here? Yep, soleus. Well done, guys. Lots of participation. That's great. This in here. There's a number of things I'll accept for this, to be fair. I say a couple of things, one of which is slightly easier to get. Yeah, very good. Sinus tarsi, really good. Or tarsal sinus, either or. And I mean, you could say, if you want to be really really on the ball, you could say it's pointed to the structure within. The main one is a talocalcaneum interosseous ligament. But I'd say tarsal sinus or sinus tarsi. This is just to very quickly just demonstrate. I don't want to take up too much time here, but really quickly, we're over the lateral aspect here, posterior at the ankle. So we've got the peroneus longus and brevis. The longus is going to come underneath and wrap under the foot. Harder to see it once you've taken on an axial plane at that level, but it's coming just posterior to it. It's what I want to demonstrate. So it's posterior, sort of cupping the peroneus brevis. Peroneus brevis tendon then runs and attaches. What does the peroneus brevis tendon attach to? Let's see if anyone's up for that. Yeah, spot on. Base of fifth. And so if we follow that tendon here, it's going to attach onto the base of fifth. Spot on. And your medial structures here is your Tom, Dick, and very nervous Harry. And so just bear in mind that this is the tendon and this is the muscle of your flexor hallucis longus. So really, yeah, spot on, guys. And again, in the interest of time, we'll just go through that. I just wanted to show again lateral aspect, brevis and longus, and medial aspect. Here, slightly harder to see them, but tibialis posterior and flexor digitorum and flexor hallucis. Okay, just a couple very quick ones to finish off. Everyone hates an ossicle in the foot, so let's just go through a few of the quick normal variants in the foot, and then you're all done. So if the question like this would say, what is the normal variant displayed on the radiograph? And then this is these are tricky. Cool. So this is the os peroneum. So this sits in the peroneus longus tendon, so it's traveling underneath the foot. So this is the os peroneum. By contrast, it's quite hard to see this. Sorry, it's quite small, but I'm talking about there's a tiny little ossicle sat just here, just where that red dot is. So then that's got a really funny name, which you may have come across or not before. So this is the os vesalianum. And this is sat in your peroneus brevis. Yeah, this is really good, guys. Well done. So os vesalianum sat in peroneus brevis just before it attaches into the base of fifth. Tiny little one here, sat just underneath the fibula. So that's an os. So os subfibulare. Very nice. This is the one that people normally come across a few times before. This is the one that's probably got slightly more clinical relevance. An ossicle sat at the posterior aspect there. Strigonum, really good. And this, I believe, is the very last one. So just got an ossicle down here, sat next to the navicular bone, and Yeah, I mean, if you're stuck, yeah, well done, really good guys. So I think with the obstacles, if you're really stuck, I would say that there is an os, and then talk about the structure next to it. And to be honest, you won't go too far wrong at that stage. I'm just going to pass over to Karen for the last minute, and then we'll let you escape. Wow.
So that's pretty much everything. I just wanted to highlight some of the revision resources that I used. So I definitely would recommend using Radiology Cafe because I did mock anatomy exams. There are a few of them. I can't remember how many there are now, but there are a number of them to get through. So don't start too early before you've done enough revision because it'd be disheartening, but do start early enough so that you can get through them all. Textbooks, I quite liked Abraham and Weir. Other people don't go for that one so much, but I thought I'd mention it. Go to your departments and see if there are any textbooks that older years have also used, and they might have left them in the department for you. In terms of websites, Radiology Academy, really good. IMEOS as well is really good for scrolling through and getting a 3D appreciation of those images. Stop and Slice, test yourself. Can you label all of those structures? Take the labels off and test yourself before you put them back on. You can also do that at work when you're reporting. Don't underestimate the value of when you're doing your acute reporting, scrolling through and stopping on Slice, maybe putting it in a weird oblique angle or something and just testing yourself. Can you label every structure that you can see on that scan? Because it's harder than it looks. Obviously within reason, just to the level of detail that you'll need for this exam. But you've got to the end of this session. We're now at almost 1:45, so we will let you go. Good luck with your exams. It sounds like you're all answering things really well so far, though. So well done. And that's it from us. Do give us some feedback, though. It's always really useful. All right.
Thank you both. That was really great. I've just posted the link for the feedback in the chat. Please, 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 if you can fill it out, that would be great. There'll be early access for everyone who fills it out. And it will be made available to all members in within 2 weeks. So if everyone can fill it out, it'd be a massive help. Thank you, everyone who's attended.
These are also our references, just saying.
Thank you. Fantastic.